So I think anybody who has been a therapist for any length of time um, realizes that patients are complex and pain is a very complex animal. I've been a physical therapist for over 20 years now. I've been a pain researcher for over 8 years, and I've been an educator for over 20 years as well. And in all of those roles and wearing all of those hats, I've come to the realization and the understanding that no two patients are the same, but also that pain is a complex entity. It's multifaceted and involves many, many things. And I also realize that it's in many ways what we've experienced in the past help to shape how we respond in the future. And so today we're going to be talking about the role and the influence that our past has upon current pain and the pain we will have in the future. We'll be taking a look at things like the trauma and past experiences through the lens of the pelvis, and taking a look at see how all these different influences will come in and potentially influence how we treat and the patients will see in clinic that come into us with pelvic pain. Now, just to give you a little roadmap of where we're going and what we're going to be doing, just to kind of set the table, because I find that talks run a little better when we kind of have a direction and an outline. And so what we're going to be taking a look at is linking pelvic pain and trauma. And so we'll take a look at beginning at determining the prevalence, how common is pelvic pain, and how common is PTSD, and how do they relate to each other. We'll look to see beyond the prevalence and next move to the mechanisms. What do we find about the neurophysiology? What do we find about the physiological mechanisms that underlie this connection? We'll talk, once we start to talk and take a look at the mechanisms, we'll move on to, is there a functional purpose that these mechanisms serve? And what is the connection in terms of function? And how does this influence what our patients present with and what we see in clinic? From a physical therapy perspective, we'll take a look at it philosophically and say, where are we at now? How does this new science and this understanding help shape what we think and what we do and how we interact and how we move forward as a profession? And then finally, how do we use this the next day in clinic? So what are the clinical implications of these findings and this way of thinking? So that's the roadmap, and that's where we're starting, and that's where we're going to be headed. So let's move forward. So taking a look at prevalence, pelvic pain and trauma and PTSD, if we take a look at some of the studies, there's actually increasing and growing numbers of studies out there. I've chosen one because of the number of studies and because it's used a lot in references and in other articles. In one study, it was a study that they took a look at just a single pelvic pain clinic. And it's mainly because they took so many measures. They took a look at 719 patients. And in these 719 patients, they asked them the question about physical abuse and sexual abuse. And in these 713 patients, they found that nearly half of the patients had experienced some type of sexual or physical abuse. So these are people with pelvic pain, remember. And so 46.8% of these people had some history of sexual or physical abuse. And of these people, they asked how many were formally diagnosed with a diagnosis of PTSD. And of these patients, 31.3% had a formal diagnosis of PTSD. And this was a study done by Meltzer and Brody et al. In 2007. So if we take a look at other research, I said there's a lot of research out there and a growing amount actually. And so much so that they could do a systematic review of 40 studies, which is fairly significant. As they looked at the 40 studies looking at the relationship between chronic pain and PTSD, what they sought to study was, is there evidence that chronic pain is associated with PTSD? And what they found is that 84% of the studies found that there was a correlation between chronic pain and PTSD. This was a study done by Fishbane in 2017. From the study, you can see that not only is there a relationship potentially between pelvic pain and trauma, but also there's a potential relationship between PTSD and chronic pain. So the question is there a relationship between PTSD and chronic pain? So, as physical therapists, we're often well acquainted with pain and the time frames and the timing that links in with pain and acute pain and chronic pain. So if you look at acute pain, we classically call this pain that exists between 0 and 3 months. And anything beyond 3 months we classify as chronic pain. So how does that relate to what we see with trauma and stress? Well, it's interesting. If you look at trauma and stress also has a similar pattern of presentation, where anything below 3 months is considered an acute stress disorder. But anything greater than or progress beyond 3 months will be classified as post-traumatic stress disorder. So you'll see a similarity in chronic pain and PTSD, that they're both the result of some type of injury or trauma that has existed beyond 3 months. But additionally, the interesting thing is that both of them started as either acute pain or acute stress disorder. They're just acute pain or acute stress disorder that did not fully resolve. And so the question is, why did they not resolve? And we'll find that the differences are more than just time. So we were interested in studying this question, and so myself and Kim Dunleavy and Louis Puntadura and Neil Spielholtz and Sam Chang, we all combined together and we took a look at the question of the role of associative learning and fear in the development of chronic pain. And what we did is we compared in this paper whether there's a link, or whether there's similarities between chronic pain and PTSD. And so some of the findings that we found in this narrative review are going to be presented in the remainder of this talk. So this leads us to the topic of trauma-informed physical therapy practice. More and more I see in literature and I see in clinical practice and just an awareness within the profession that chronic pain is linked to trauma. Not all chronic pain is linked to trauma, but there is a potential link in a good number of people where chronic pain is linked significantly to trauma. And so for physical therapists, one of the things we need to start to do more and more is to start to realize that there is a link, and then to shape what we do and what we practice and how we interact with patients with this knowledge and understanding that trauma impacts our patient. So trauma reshapes our patients' lives. The question is how, and how do we use this information to start to change and shape the way we interact with our patients? And the beginning of this starts with, how does it reshape our brain? So we start to turn our attention away from the prevalence and into the mechanisms that underlie some of these connections. We find that most of our responses in terms of pain are really learned responses. So more and more we're learning that pain is a learned response. And we learn it from past experiences, and these past experiences then shape how we respond to future stimulus and future pain. And so about 90 to 95% of our learning actually occurs at a subconscious level. And these subconscious levels are driven by changes we see in our neural pathways. And so much of the foundations of learning occurs not at the conscious level, but at the subconscious level. And why is this important to us? Well, because most of the last 20 years, I would say probably most of the last 50 years, a lot of our attention in physical therapy and in medicine and any of the pain sciences has been really about trying to define what the biology is that underlies pain. And we've gotten pretty good at it. We don't know everything about pain and the biological mechanisms that underlie it, but we have a better understanding than we did 50 years ago and even 20 years ago. And from this, we've learned that nociception and pain are different animals. Before, we used to think that nociception and pain were the same animal, but we now know that they're completely different. Nociception occurs in the periphery and is routed to the brain. And nociception is really about tissue injury. It's those pathways that go from the periphery up to the brain that informs us of something being damaged. These are our C fibers, our A delta fibers. They go up spinal thalamic tracts. They route up through the brainstem and into the brain and activate certain areas of the brain. This is nociception, but this is not pain. Pain is really a brain response. It's not solely a brain response, but the brain is involved in the response. And so initially, researchers looked to identify a single pathway or a single region of the brain responsible for trauma and pain memories. But as they start to look, they came to the quick realization that pain is not processed the same in the brain in every single person who has pain. In fact, it's processed differently in every single person. And so finding a single fingerprint that is identical for every single person that has pain was something that we could not find. So the fingerprint for pain does not exist. But what we did find from doing multiple studies and multiple imaging is that there are patterns of activation that are similar for most patients with chronic pain. And from these patterns, we've gained a lot of information about what's pain's purpose and what pain does. And so if we start to take a look at these patterns, brain scientists like to break down these patterns into networks of patterns that are activated in response to different stimulus. Since we're looking at it from the context of pain, we'll look at the stimulus as some type of nociceptive stimulus or some type of painful stimulus, and what kind of activation we get in the brain when we stimulate these pain receptors or these nociceptive receptors. And so as we break down these networks, we break them down for classification purposes to help us understand it better. And we come up with 3 classifications. One is the default mode network. The second is the salience network, and the third is the central executive network. So if we look at beginning with the default mode network, what we find is the default mode network is really designed to regulate what we do during the day. It primarily works subconsciously. It works in the background. We really don't have to really think about it at all. In fact, we don't think about it at all. And so this is the default node network or the series of structures that are activated when we're daydreaming, when we're just not thinking about anything, when our mind is wandering. But as soon as we get startled or we have something that comes into our awareness that is unusual or different, then we activate our salience network. And this is really our scanning network. It's our network that looks to see, is there anything different in the environment? Is there anything that's changed? If it is, then what is it? And it starts to activate those types of networks, or those parts of the brain, those areas of the brain that are involved in this network. And the final network is the central executive network. And the central executive network is that network that acts at a conscious level, whereas the default mode and the salience network primarily worked at a subconscious level. Now, the central executive network, what it does is it takes a look at the information gathered from the salience network and says, what does this mean and what am I going to do about it? So it's really a decision-making network, and it looks at memories and past experiences and helps us determine what our responses should be. So it's interesting, when we start to take a look at people with chronic pain, we find that there's disruptions or differences from people who don't have chronic pain. And we look at people with trauma, and we find similar patterns of activation. So what do we find? We find that the default mode, this area that we're wandering and this area that is just letting us kind of daydream, it is not as active. There's actually decreased amount of activity in this network. In both trauma research and pain research. What else do we find? Well, we find that the salience network, this network that's designed to monitor our environment, to look for threat, to say what's unusual, this gets activated at a higher level. So there's increased activity for prolonged periods of time. And what else do we find? We actually find decreased activity in the central executive network in both PTSD and chronic pain literature. And so we find that there's not a lot of decision making that's occurring. A lot of these things occur at a subconscious level and automatic level. And if you look at that diagram on the right, or that graphic on the right, it just shows you some of the structures that are involved with these different networks. So if you start to take at the default mode network, you look at the posterior cingulate cortex, and you'll also see a lot of brainstem activity. If you look at the salience network, you look at the insular cortex, you look at the amygdala, the temporal gyrus, and the dorsal anterior cingulate cortex. And if you look at the central executive network, you start to look at things like the prefrontal cortex, the posterior cingulate cortex. And so these are the areas that are involved in the brain when we have trauma and when we have chronic pain. So what does this mean? Well, we talked about how our alert system is activated, how our relaxation system is deactivated, and how our central processing or our decision making is deactivated as well. But we also find that in terms of PTSD and in terms of chronic pain, there's a huge overlap in these areas, because a lot of these areas, especially the salience network, those areas involve the anterior cingulate cortex, the insular cortex, and the medial prefrontal cortex. These have functions, and a lot of these functions are related to memories, but specific type of memories that process emotion. And so it's not any wonder that we find a strong correlation in our patients between patients who have chronic pain and people who have depression, anxiety, catastrophizing, sadness, anger. All of these different types of processes and all of these different types of emotions are processed by similar areas of the brain that are impacted with chronic pain, but also with PTSD. So as a clinical pearl, it's interesting if we start to link and tie PTSD and chronic pain together, because of the science, because of the prevalence, because of what we see in clinic, we start to see some common patterns when we start to take a look at our patients. It's interesting, if you look at people with PTSD, really people with PTSD, you start to classify them into two different types of presentations clinically. You'll see those people who come in hyper-aroused, like amped up, and they can't calm down, and everything is a startle response. And you can see just by looking at them how that warning system is activated, and how much it's influencing how they work and interact with the environment around them. But also you'll see those people who dissociate and avoid. And so what they'll do is, instead of being hyper aroused, they'll go into themselves and not be able to interact with the world, because the system shuts down on them. So how's that have to do with chronic pain? Well, it's interesting. In chronic pain, we'll see our patients, they'll either start to come in hypersensitized as well. Instead of hyper-aroused, they'll be hypersensitized. You might see hyper-arousal in terms of their interaction, but their nervous system is hyper-aroused, and we call that sensitization. But also we can see a blunted response where there is no response, a flat affect, they've given up. And this is a dissociation that we can see in our patients that kind of parallels what we'll see in people with PTSD. So the question is, if we don't really have a pain fingerprint, and it really involves patterns of activity and networks of activity, but it's not identical to any two people, that everybody's a little different, should we really be focused on the biology of things, or should we start to change how we take a look at things? I know as physical therapists, oftentimes we like to focus on the biology and the physiology, because that's our comfort zone. Brain sciences is like crack for the pain therapists because we love that information. We can't get enough of it. We like to say, oh, this is what's happening with our patients in the brain and in our nervous system. It helps us understand our patients a little better. But when we really turn it to our patients, having an understanding of this, how does this impact how we interact with our patients? And I would argue that the biology of it helps us understand a little bit, but really it's when we turn to the function of these areas that we get the most bang for our buck. So switching our focus away from the physiology and to the function is a critical paradigm shift to help us start to understand people with chronic pain and our patients with pelvic pain, and help us move forward as clinicians and as a profession. So if we start to shift our focus away from the physiology and more towards the function, we have to understand what the purpose of pain is. And the biggest changes occur in the salience network. So why do these changes occur, and what does it mean to the function of how we interact with our patients? Well, remember, the salience network scans our environment and scans our surroundings for potential threats, whether it's from trauma or whether it be from pain. And why do we scan the environment? It's because we're looking to try and protect ourselves. And so pain is really a protective mechanism. It protects us when we're injured, but the question is, does it also have long-term impacts for us? So pain and the salience network really is utilized by the body to help avoid dangerous and life-threatening events, whether it be actual, and this is the key, or perceived. So classically, we look at pain as a reactive response. We step on a tack, we step on a Lego, we sprain our ankle. What happens is we start to get pain in our ankle, and we also start to get nociception. These are natural reactive responses. It's designed so that we can pull our foot off that Lego, that we can stop putting weight on that sprained ankle. So it's designed to help tissues heal and to avoid further damage. It's really a protective response. But what happens when we have chronic pain? We no longer have this tissue injury. We no longer step on that Lego. Why do we still have pain when our tissue is not damaged anymore? Well, in these cases, pain is really a proactive response. It's designed to take control and predict things that are going to happen. So if we start to learn from our past mistakes or past experiences, it helps us respond more efficiently, more quickly, and to enact these survival and protective responses in a more efficient manner. So with this knowledge and through this lens, we start to take a look at pain from a functional perspective. We really learn that pain is a learned functional response. But it's a learned response that requires specific types of learning. And so we need to understand the different types of learning that exist to really have an understanding of where pain lives and where pain exists. So most of our memory is stored subconsciously. We kind of talked about that earlier. So there's really two types of learning if you generalize it: explicit learning and implicit learning. Explicit learning is a conscious learning, and it occurs about 10% of our behavior. So if we're listening to this on-demand session, or if we're reading about it, or if we're studying for something, or if we're trying to learn or remember a list that we're supposed to buy at a grocery store, then that involves explicit memory because it's a conscious process that we do. But only 10% of our learning during the day involves this type of memory. Most of the memory involves implicit memory or implicit learning. And so the implicit learning, it really occurs at a subconscious level. It's 90% of what we do. It's the majority of that iceberg occurs below the water level. And so a majority of our learning occurs below the water level. So pain's a learned response, and it involves implicit learning. Is there special classifications of implicit memory? Well, there is specific classifications of implicit memory. There's things like priming and procedural learning. These involve things like the skills that we learn if we're trying to learn how to play golf, or we're trying to learn how to drive, or we're trying to learn how to play tennis. We repeat that technique or that method over and over and over and over again. At the beginning, it starts at a conscious level, but pretty soon we don't have to think about it anymore because it's become a skill. It's become a habit. We've learned it from a procedural perspective. But pain, that involves a different type of learning for the most part. It involves implicit learning, but more of an associative type of learning, and sometimes non-associative types of learning, such as habituation and sensitization. We're going to focus our attention more on the associative learning that occurs in people with chronic pain, and specifically as it links to PTSD, because there's increasing evidence to suggest that PTSD as well, trauma learning, involves associative learning, or classic or operant conditioning. And so we're going to take a look at that. So how is pain and how are trauma memories formed? Well, if we start to take a look at this implicit memory, really there's a process that it goes through. And that process is acquisition, encoding, storage, and recall. And so these are the processes involved in forming these type of pain and traumatic memories. Acquisition really involves when we step on something, when we're injured, when we're traumatized. What happens is we take in all the information from our environment. So we're acquiring all this sensory information, all this interoceptive information, all this contextual information, all these emotional information, and we're bringing it into our body and into our brain. And what we do is the brain starts to process it. As it starts to process it, it starts to encode it. It breaks it down, encodes it for storage. And once it's encoded, we store it into our short-term memory. And once it's stored into our short-term memory, if we need to see it, if we re-experience it, if we're triggered again, we recall that memory, and that's when we start to experience the trauma again, or we start to feel pain again. So it's this process of acquisition, encoding, storage, and recall that occurs. So with pain and with PTSD, how is associative memory formed? Well, really, it goes back to the 1900s. And so most of you are familiar with Pavlov and the studies he did. Pavlov did a study with his dog. His dog's name was Bear. And so with Bear, what he did is he put sensors into Bear's salivary glands. And then he presented Bear with food. And what did Bear do? He increased his saliva levels. The interesting thing is, though, is as Bear was being exposed to the food, he also started to expose Bear to a bell. So he rang a bell and gave Bear food at the same time. So what did Bear learn? He learned that whenever the bell was associated with food, then the salivary glands start to activate. Pretty soon, after a while, Bear learned that their bell was associated with food, and so that whenever the bell rang, the saliva glands activated. And so that was a process of learning where Bear started to associate food with the bell. And pretty soon the bell can produce the same response that the food did. Well, what does this have to do with trauma, and what does this have to do with pain? Well, a similar process occurs. Well, if someone's hit on the head with a ball, then we're going to have pain. What happens if we are hit on the head with a ball and we experience some type of sensation in the environment? We'll use a bell because it kind of relates to the dog or the Pavlovian experiences. And so say we have a horn or a bell that rings at the same time that we are hit on the head with a ball. Then what we do is we just begin to associate that horn with getting injured. And pretty soon that horn can be a stimulus for pain, just as the bell was a stimulus for saliva production. And so you can see how the bell and the ball became associated together to cause pain. So in this case, environmental context, contextual context, can become that bell that rings, and it gets paired with the injury and soon becomes a stimulus for changes in our pain perception. You'll see on that diagram on the left, context becomes an unconditioned stimulus, such as the bell ringing became an unconditioned stimulus, whereas the injury or the food or the trauma are a conditioned stimulus, and they get paired together to produce a conditioned response, whether it be salivation in bear or pain in our patients. Now, we're at the very beginnings of this research, and as we begin to research it, we realize that we're at a point to say that things like the bell and things like the ball, things like environmental context, things like the things that happen in our environment can potentially change our pain responses. We're not at a point at this point to say that it causes our pain. So we need future research to take a look at that, but let's take a look at some of the research that developed around this. So it's interesting, if we start to take a look at associative learning, there's a growing body of research that's growing. And a lot of this research is occurring in countries that are around the world. So it's just not a US thing that we're trying to look at it. Really, the beginnings of it actually is in other countries. So if you look at Madden and Harvey, Mulders, they are all doing work in different parts of the country, whether it be Europe, whether it be in Africa, South Africa, or whether it be in Australia, or even in Washington with Jensen. We are starting to look at how subconscious learning can be associated with some of the things that we're seeing in our patients, some of the associative learning that we're experiencing. And so the interesting studies that were done by Madden, Harvey, Mulders, and Jensen is they start to pair subconscious learning to see if the things that we experience in our environment can start to shape and change our pain perception. So they've done interesting lines of research. And so some of the research takes a look at taking a tool that it vibrates and monitors and changes the frequency of vibrations. And you place that in one hand and put a pain stimulating device in the other hand. And what you would do is whenever you hit a certain frequency in the vibrating hand, you gave them a painful shock. And you kept doing that at the same frequency over and over and over again. And then what you did is you measured someone's pain threshold. Pain threshold it being the amount of pressure it takes when someone first starts to say they have pain. So you start to measure that. And whenever you hit a certain frequency, that same frequency which pain was generated, it's interesting that the pain threshold changes. And in most cases, it reduces. So people feel pain a lot more quickly. And so what's the interesting thing about that? When you ask the patients, you say, hey, do you notice a change in the vibration in your hand? They said, no, you didn't change the vibration. It all occurred at a level that occurred below the conscious level. They've done additional experiments that looked at flashing pictures in front of someone. And whenever they hit a certain picture, they gave them a painful stimulus. Then they re-showed them those pictures later. And what happened is when they hit the picture that was associated with the painful stimulus, their pain thresholds changed and reduced. And you ask the patients, have you seen this picture before? They'd say, no, I've never seen that picture before. And so the interesting thing is that subconscious cues that people are unaware of can shape and change our patient's perception of. And it also changes and shapes those areas of the brain that are responsible for processing pain and responsible for processing trauma. That was some of the work that Mulders and Jensen took a look at. We've even gone so far with this research to suggest that, pain that we have involves associative processes. And so Mosley and Veiling, they really start to take and consolidate this information and come to the realization that pain really does involve associative learning principles. Now, from our research that we're doing at our lab, we start to take a look at, well, it's interesting that subconscious pain activates these. What happens when we consciously get people to remember their past traumas? Does that involve or does that change pain perceptions? So in this study that we conducted, we actually took a look at 60 subjects. And in these subjects, 30 of them had a prior history of trauma in their leg. and 30 people had no history of trauma in their leg, and we used that as our controls. And what we did was we measured a couple things. We measured, one, is there change in their pain pressure thresholds? And two, we said, is there changes that occur in their movement and motor recruitment patterns? And so what we did is we put them under 3 experimental conditions. One experimental condition is, let's just give you acute pain into your leg and see, is there a change in your pain thresholds, and is there a change in your motor responses? The second thing we looked at is said, okay, we want you to remember that pain that we just gave you. We just want you to remember that acute trauma that we just gave you. And so when we did that, we also took a look at, is there a change in pain thresholds, and is there a change in isometric muscle strength? And the third thing we looked at is there a change if you remember your acute trauma or your long-term trauma? And so we measured the same things. Is there a change in pressure thresholds? And is there a change in isometric muscle strength? And the interesting thing we found is that in terms of when we had them remember their short-term pain, so when we had them take a look at short-term pain memory, or when we had them remember nociception, they had a 15% reduction in isometric muscle strength, and they had a similar reduction in pressure pain threshold. When we had them remember their trauma, their long-term trauma, they had a 24% reduction in isometric muscle strength and a similar reduction in pain thresholds. And so that shows you that memories can reduce someone's muscle strength, but it also can have an impact on a person's pain thresholds, whether that's pain memory just associated just recently or even years in the past. So just as a recap before we move forward, really pain is a learned response. Most of our learning actually occurs at a subconscious level, and subconscious and conscious cues from our environment, both external and internal, can potentially trigger these protective responses. And trauma enhances this process. So we talked about how this information, how do we start to use this from a PT perspective? And do we need to start to change how we look at our patients and how we start to address people with chronic pelvic pain? You know, in the past, we've been really tied to medicine. We looked at the biological factors. We looked at how the brain changes, how our peripheral nervous system changes, and that's been the focus of a lot of what we've done over the past 50 years. But more and more we're learning over the past 20 years, and more specifically even the last 10 years, there's just been a huge growth in our understanding that pain goes beyond the biology. Pain really involves psychology and our mind as well. And so the question is, who do we start to align with philosophically? Should we still be aligning with medicine, or should we change and start to shift our attention to more what's occurring in the mind and align ourselves more with the psychological field? And this leads us to a place where we stuck kind of in the messy middle, and chronic pain and trauma-informed practice lives in that messy middle. So really, do we need to start to change the way we think about and manage pain? Because pain is not just a biological response. Pain involves integrating the new science that involves both the brain, both the psychology, and as well as the social factors, the contextual factors that shape our pain responses. And so a modern pain framework in terms of pelvic pain and patient management really involves taking a look at moving away from the biological theories, such as the specificity theories and the gait control theories and the neuromatrix theories of pain. Not necessarily throwing them out, but realizing that pain is not solely the biology, but it also involves the psychological and also the social factors that are involved in pain processing. So that's moving more towards a biopsychosocial pattern. or biopsychosocial model of pain, more towards a fear avoidance model of pain management, more towards a pain adaptation model, or somatic and sensory motor therapy models of treating people with pain. Psychology has started to step into this gap, and I'm afraid that physical therapy is missing the boat, because if you look at psychological fields, they have things like somatosensory and somatomotor therapies, where their primary focus is taking a look at the psychology, and psychologists say that, oh, I take a look at psychology of what's going on with these people, and what I do is I have them start to move. I have them start to interact. I have them start to use my hands through tapping or through touching. And what I can start to do is I can start to engage and interact with my patients more efficiently. And this is psychologists starting to move into the gap that physical therapy is not filling. So my argument and my fear is that we need to start to fill that gap, because we are the profession that is best adapted to be able to live in the biological world and in the psychological world and fill this gap where we start to interact with our patients, not only from a biological perspective, but also from a psychological and social perspective. And it's with that mindset that we continue on. So what are some of these clinical implications as we start to dive into that gap and fill that messy middle? Well, clinical implication one is, if pain is a learned response, how is memory stored? And so we learned from PTSD literature that really this process of acquisition, encoding, and memory storage occurs over the period of about 30 days. So what happens is this information is acquired and it's encoded, and it's really stored in working memory. And it's stored in working memory for about 30 days. And what happens during this 30 days, this trauma is kind of just stored kind of there. After 30 days, our brain starts to say, okay, you know what? We're going to have to figure out what to do with this stuff. And so at 30 days, it decides, am I going to keep it or am I going to throw it away? Am I going to move it to long-term storage or am I going to get rid of it? So strategy number one is, in order to prevent the long-term storage of pain memories and trauma memories, we have a 30-day window really to start to change our patient's perception. So we have 30 days to take it from, oh my gosh, this pain that I've experienced, this trauma I experienced, I need to store a long-term memory of this, because what if I don't store it? I am going to be in jeopardy, and I'm going to be potentially in danger for the rest of my life. So I'm going to store this memory so that if it comes up again, then I can respond quicker to get away and to live and survive. If you could start to de-escalate these patients, if you could start to take away this perception that they need to store a long-term memory of pain, then it's no longer stored. And so one of the biggest things to prevent chronic pain, or to treat patients with chronic pain, is not to allow them to get there in the first place. We have a 30-day window to do that. The second thing that we have to realize is that pain is learned, and it's also learned associatively. So we have to realize that just like Pavlov, where a food and a bell got linked together, pain and factors, injury and factors get linked together to cause pain. And so we focus on the physiology. What we need to start to focus on also are these other factors that got linked together, that in turn changes our patient's response to stimulus. So it changes our patient's sensitization, it changes our patient's pain thresholds. So what are these factors? Whether it be a sound, whether it be a sight, whether it be a memory, whether it be emotion, whether it be internal, such as proprioception or baroreception, or the changes in hormones. What of these factors may be contributing to our patient's pain because they've been locked in and now become triggers? We start to take a look at people with pelvic pain. I treat a ton of patients with pelvic pain. And in these patients, you'll start to see this pattern sometimes that their symptoms, whether it be back pain or pelvic pain, get exacerbated or increased when they have their menstrual cycles. So always the thought is, well, maybe there's more inflammation that occurs. Maybe that just becomes more sensitive because of the amount of inflammation that occurs. But equally, it could be said maybe the reason that they get more sensitive is because their system has learned to associate certain things. It can pick up change in the hormones, and these changes in hormones act as a trigger to start to sensitize the system in anticipation in order to protect the body, and becomes this learned behavior. So clinical implication number 3, if pain is a learned response, changing memory often involves recalling the memory as well. There's a debate in physical therapy and in the pain world. Should you get people to talk about their pain? Should we get people to remember their pain? Or should we avoid pain talk altogether? So when a patient comes in, we don't talk about pain. We move forward to function. We get them moving forward. We avoid pain talk at all costs. This is kind of interesting. And my take on it is that really if we're going to change someone's pain, then we have to really take those memories that have been developed. And what we have to do with these memories is we have to start to change them. And we can't do that unless we recall it. So we recall the pain, we change and shape it, whether it would be desensitize them to the triggers, we teach them new patterns that have different outcomes. But whatever the reason, we recall the pain, we change and shape it so it can be re-encoded, restored in the brain. And so that when it's recalled, it has a different outcome and different response. And so I think that in order to change someone's memory, we have to recall it and re-encode it. Clinical implication 4, if pain is a learned response, then using PT to change these pain responses is what we have an advantage over talk therapy, over biological sciences, over pharmacology. We have the ability to start to change these responses at a subconscious level because we have tools that we can utilize. Psychology is somewhat limited because it's talk therapy, and talk therapy just involves the conscious system. Over time, you can start to activate and engage the subconscious, but really it's usually in the executive network and the conscious memory to start to drive changes in the subconscious systems. Really, as physical therapists, we can talk to our patients, we can start to engage them and start to change through talk therapy as well, but we have an advantage over some of the other professions because we can engage the subconscious system. Things like breathing involves the subconscious system. Things like touch activates our autonomic nervous system, and we can change subconsciously through touch. Through movement is subconscious system. Most of the time when we're moving, we're not thinking about how we move, we just move. And so we can engage the subconscious system through movement, through mindfulness, through education, and through the relationship we build with someone. Healing occurs through relationships and alliance, and it occurs at a subconscious level. And so we can start to engage these systems, all with the intent of changing our patients' pain responses. So in summary, pain is more than a biological response. In the case of trauma, in the case of pelvic trauma, in the case of abuse, pain is very much like PTSD. It's not the same at this point. We're not at the point where we can say that chronic pain is PTSD or PTSD is pain, but they are close cousins. They run very much in parallel pathways. And so these traumatic experiences are stored in memory. And when they're stored in memory, when they're recalled, they can shape our pain responses. Management, therefore, involves preventing the formation of these long-term memories. We have a 30-day window to start to change these memories. But also, if memories have already been formed in a lot of our patients, management a lot of times involves identifying the cues and triggers from the external and internal environment that are changing our patients' sensitivity. that are changing our patients' responses. And then management involves slowly and guiding exposure to these memories, starting to learn to get our patients to change their responses so that they can create new positive memories, so that when they hit these different triggers, these different cues, instead of sensitizing the system, they now have a new outcome, a different outcome. And in reality, we never erase our memories. Research is showing that memories are never gotten rid of. But what we do is we start to develop new memories on top, so that these older memories are driven lower and lower and lower, so that our responses, our primary responses, are different. They're better. And that's the goal of physical therapy. And that's what we can do as physical therapists in treating our patients that have pelvic pain. So I've really enjoyed the opportunity to get a chance to chat with you. Thanks for listening to me. It's always exciting to share what we were working at in clinic and what we're working at in our pain lab to help to move our profession forward. And so we welcome any questions that you may have. You can engage us through email, and we're more than happy to respond to you. Thanks for listening, and we'll see you around.